This is July, start of the new academic year, and we have to talk about sepsis, which is a major point when your hospital is evaluated, major point when your programs are evaluated. So we have the expert here. This is like how many, we should give you a plaque. How many times have you done this for us?
Every year.
Anyway, Laurie.
Thanks.
Okay, thank you.
You guys hear me in the back okay? Excellent. Well, thanks for coming for our semi-annual sepsis lecture. But it's important information, and it's something that no matter what department you're in, you're going to see a septic patient. So we're going to go ahead and talk about sepsis and some other stuff today. Just to keep it interesting, I'll wait to do the other stuff at the very end, so this way I know that you have to stay. I have nothing really to disclose because Dick doesn't pay me anything. So from that standpoint, our objectives, basically we're going to talk about kind of the continuum of where we were when we kind of started talking about sepsis many years ago, all the way through where we are today, and really kind of spend a few minutes on the changes that happened in 2016 and why those changes occurred. We're going to talk a little bit about hemodynamic optimization and fluid management because that's part of treating your septic patient. Then we're going to go through some other stuff that's popped up in the last 2 or 3 years related to our septic patients. Now, I show this slide every year just because when I first started in critical care 2 or 3 years ago, because I'm not that old anymore, basically, stop laughing. So, you know, nobody really would talk about sepsis. It wasn't one of those big deals that really hit the mark when we talked about disease processes. You know, it even got to a point where one of my nurses didn't understand why every other disease had a 5K. Why don't we have a 5K? Why don't we have our own ribbon? Why don't we have our own wristbands? To the point that she actually sent a couple emails to Oprah wanting to bring sepsis to the forefront, to the point where I think she probably has a restraining order against her from Oprah. I'm not really sure at this particular point in time. But once it started hitting certain major players, like, you know, when Superman or the Pope or Kermit the Frog developed pneumococcal pneumonia and got septic shock and died from it, you started hearing more and more about it from the lay population, and people wanted to know more about sepsis. And it started hitting the lay publications. And when you take a look at where we are, and I know that every year we throw up the 750,000 cases of sepsis, but the number just keeps getting higher and higher. And those of you that take care of critically ill patients, you see it, that, you know, more and more times, you know, you get phone calls from patients. Of course, every phone call you get, every patient's septic. It's as simple as that. Either every patient is septic or every patient needs ECMO. There's nothing in between. And I even had a patient one day that I got a phone call from a physician to transfer them because the patient was septic. And I'm like, well, what makes you think that they're septic? I said, well, they have SIRS criteria. I said, well, what happened to the patient? Well, they fell and broke their femur. I said, well, when did they do that? Well, about an hour ago. Are they septic? I said, well, no, they're tachycardic, they're breathing fast, they're white. I said, yeah, they broke their femur, they've got a broken leg, they're not septic. But as you look at the numbers, you can see the numbers are going up significantly. So we need to pay attention to it, and we need to know why we're here today. I wanted to put a slide in and just kind of put a picture of Dr. Weigel up here and say this is why we're here today, because Dick asked me to come. But where did we start? Well, many, many moons ago, there was a group of physicians whose names for me mean a lot. You know, Roger Bone was like, you know, the guy when you talked about critical care. And I actually had the opportunity as a fellow, actually rounded with Dr. Bone in MI. Got to take him around, make rounds with him. You know, I know Bob Bach. I've met Frank Serra, Phil Dellinger. You know, as I get older, I think to myself, God, when did I get so old? Because all these guys are really, really freaking old. But the truth is, I had the opportunity as a fellow and a young clinician to actually meet with a lot of these guys at different meetings and interact. But back in the late 80s and early 90s, one of the things that I noticed is that I got a lot of things. It's really weird. It comes to a box, and it's a piece of paper, and they put it in there, and you open it up, and you have to read it and fill it out. It's called mail. It doesn't come on your phone for all you young guys. It's called mail. But we'd get these census and questionnaires and surveys, and they would ask us, what's your definition of this? What's your definition of that? And they put it all together, and these guys got together. I'm not sure what island they were on, but I'm sure it was really nice. And they got together, and they took these 6 words and put definitions on them. And these became the pillar with which we started to build the consensus definitions of sepsis, severe sepsis, septic shock, and multi-organ dysfunction, to the point that the Sepsis Continuum was built. And we're all familiar with SIRS. There's 4 components to SIRS, where you have an alteration of temperature, you have tachycardia, which they use 90, physiology we were taught it was 20, but 100, but that's just what it is. Alterations in respiration, where the patients are tachypnic, they're dropping their PaCO2 because they're breathing off their PaCO2. Patients that require any sort of either minimally invasive, CPAP, BiPAP, patients that are intubated, anything like that would meet criteria for the respiratory. And then alterations in patients' white blood cells, whether they have an elevation greater than 12,000, less than 4,000, or have a bandemia. And when you take these, but you have to keep in mind that SIRS is very, very nonspecific. It's an inflammatory markers of inflammation. It doesn't give you a definition of infection. I mean, think about it. If you guys were right now, it's 90-something degrees outside. I asked you to go outside, run around the building 3 times, and come back. Everybody in this room would meet SIRS criteria, but you're not septic. You just met SIRS criteria. If you added SIRS criteria to a presumed or confirmed infection, then you had sepsis. Now keep in mind, you don't have to have a bacterial infection to be septic. You can have a viral infection, fungal infection, parasitic infection. It's just an infectious process. Most commonly, we always think of bacterial, but it doesn't have to be bacterial. It can be any organism that can cause it. You add one end organ dysfunction, and it becomes severe sepsis. And if that end organ dysfunction is cardiovascular, or they're hypotensive despite having had a volume resuscitative effort that was optimized, and they're requiring a vasopressor, you then meet septic shock. And for years, this was it. We finally went from a disease process that nobody cared about, actually having definitions, a continuum, and something that we could talk to each other about as intensivists, and everybody knew what we were talking about. Everybody was on the same page. When we looked at organ dysfunction, we thought, is it important to know that there's different organ dysfunctions? The answer to that is yes. There's 7 different organs that we think about when we think about organ dysfunction. Now, we always talk about the big 3 being respiratory, cardiovascular, renal. But keep in mind that there's 7 total. Anything related to altered mental status, you have neurologic changes. Of course, anything related to respiratory, which we've talked about, cardiovascular, which we've talked about, and renal, which we've talked about. But keep in mind, number 5 right here, elevated liver enzymes. We're going to talk a lot more about lactate in a little bit for metabolic failure. And the big one over here, when I was training, you either had patients with septic shock that were with or without DIC. We come to find out that's just all part of the hematologic organ dysfunction. And the guys that work with me know how I feel about platelets. Platelets are probably one of the top 2 or 3 things that are indicative of how sick your patient is and what your outcome is going to be. The lower the patient's platelet count and the rapidity with which it hits that number is indicative of outcome. That's why we talk about TAMOF so much, because patients who come in with a platelet count of 300,000 and in 12 to 24 hours it's now 60,000 have a very bad outcome. Whereas if they come in at 300,000 and they drop to 280, it's not such a big deal. So there really are 7 organs that we pay attention to. And we pay attention to it because it's important that the number of organ dysfunction is equivalent to mortality. And when you look at the 80-something-year-old nursing home patient that comes in that has 5 organ systems down, and you go have a conversation with their family, you can tell them their mortality is 85, 90% just from the number of organ systems down. And they'll be a lot easier to talk to about shifting to comfort care and limiting what you're going to do. At the same time, you've got a 21-year-old that comes in with pyelonephritis that has 5 organ systems down. You know you got to move fast. You can't just dilly-dally with them and wait 24 hours to see if they're going to get sicker. You know flat out that if you don't do something as fast as possible, they're going to be dead in 24 hours. So knowing the number of organs and which organ systems are down is extremely important. And for years, we used this information. As I said, everybody was on the same page. We could have conversations. We knew what we were doing, and we moved on from there. In 2003, FCCM and ACCP asked others to join. And you ended up with the European Society came into it, ATS came into it, the surgical societies came into it. And everybody again met at some place very nice. And they reviewed all those previous definitions, the continuum, because they wanted to update, they wanted to change it. And the answer was, you know what? Finally, in the world of critical care, everybody's on the same page. Why change it? So they left it alone. But they came up with something called the PRO staging system. What they were trying to do was they thought about how our oncology colleagues have the TNM staging. And that when you talk about breast cancer, you talk about thyroid cancer, you talk about any sorts of cancers, everybody was they knew exactly how severe it was when they talked about the staging. And they wanted to do something similar to that by using the PRO system, using predisposition, insult or infection, response, and organ dysfunction. Although everybody thought, it's a great idea, it never really went anywhere. But at least it brought up a topic for trying to stage how severe the severe sepsis was. And what they finally agreed upon was to take the previous sepsis 1 definition and kind of expand it in that, bring it more to the forefront, what you're looking at for different temperature changes, what you're looking at for different inflammatory markers, hemodynamic variables, and organ dysfunctions, bring all that more to the forefront and make it more obvious how sick patients are that have sepsis. So again, they left it alone and they said, okay, we've got everything, this is where we are, everybody's on the same page, we're good to go. And then one thing that did come up was pathophysiology. We have a disease process that's finally brought to people's attention, but the pathophys behind it became very, very important, and lots of research was being done at that particular point in time. Now, the scope of this particular lecture, there's no way I can cover all the pathophys, but basically there's microvascular dysfunction that leads to hypoperfusion and hypoxia in the tissues, and as that happens, you get further organ dysfunction. And the interesting thing related to the pathophysiology is that when you think about the pathophysiology, how does somebody who comes in with a urinary tract infection end up with multi-organ dysfunction? The answer to that is because it's a disease process of the microcirculation, and all of these things occur pathophysiologically, and that's how you go from a simple urinary tract infection to something that can actually kill a patient by knocking out all the different organ systems. And like I said, this particular lecture is not on pathophys per se, and that takes another couple of hours to go from there, so I didn't really want to delve too deeply into it. But in 2004, they said, okay, we're on the same page, we've got the definitions, we know what we're doing, but the one thing that we haven't covered in these definitions was how should we treat the patients. Physicians that are at major academic centers or trained at academic centers, when they go out, they know how to treat sepsis and septic shock. The problem is, a lot of these smaller centers, smaller hospitals, et cetera, older docs, we didn't have a consensus on how to manage those particular patients. So in 2004, the Surviving Sepsis Campaign met for their first meeting and was published in Critical Care Medicine. And what they did was, of course, they pulled all the evidence-based medicine, put it all together, looked at the grade of evidence, and then made their recommendations. And from there, we got this graded from A to E on what they thought was the best way to treat the severe sepsis patient. They took all that information and they made the infamous bundles that we all know and love so well. Now don't stare too much at this, because every 4 years, it's kind of like an election or the Olympics, they meet again. And in 2008, they did. They met again and they said, let's take everything that we learned from the previous 4 years everything we learned about those bundles in the previous 4 years, let's pull new literature, put it together, and revamp what we're doing. And they did. Basically what they did is they just took it, and this time they gave it a new name. Instead of the 6-hour bundle, it was the resuscitation bundle. Instead of the 24-hour bundle, it was the management bundle. Instead of just an ugly black and white picture, they actually gave them colors. So they revamped the Surviving Sepsis campaign and the sepsis bundles. Now, when you look at this in 2008, there was very little argument about anything in the resuscitation bundle. Most people were in agreement with them, didn't think it was a big deal. They're like, yeah, we're good with it, we're going to do this. But there was a lot of argument with the management bundle, a lot of argument on this. And for as many articles as you could pull that were pro one of those variables, there were just as many articles that were con. So although, like I said, nobody argued anything here, there was a lot of pushback and a lot of issues related to the management bundle. So based on that, there was still some, what do we do, what do we do, what do we do? So that in 2012, they focused more on what should we do. And what they decided was, we're going to focus more on severe sepsis itself, the level of organ dysfunction the patients are having, but we're going to focus on the 6-hour bundle. And we're going to break the 6-hour bundle up into what needs to be done in the first 3 hours, measure the patient's lactate, get blood cultures, give antibiotics, and volume resuscitate your patient. Once you've done all of this, then you can shift down to the next 3 hours and go from there. And I think one of the things that you're starting to see in 2012 in this is that the word lactate pops up a bunch. And the reason behind that was because when you start thinking back to physiology, that first year of medical school, we learned a lot that we didn't realize we were learning. And we could not for the life of us as freshman medical students figure out, why are we learning all these pathways? What do we care? When are we going to see something like this walking in the emergency department for us to treat? Well, we're not. But what we learned, when you go back and you look at the Krebs cycle, is that a patient who is aerobic, and has aerobically functioning mitochondria, are going to make 38 ATP per cycle. So no matter what's hitting that particular mitochondria in that cell, there's plenty of ATP. And the ATPs, whatever you hit them with, we've got plenty. So supply, demand, plenty supply, not a problem with demand. However, in the hypoperfused mitochondria, all of a sudden you shift and you're only making 2 ATP per cycle. So you've gone from supply and demand where there's plenty of supply to supply and demand where there's none. And that's when you start seeing dysfunction of those mitochondria. And as those mitochondria dysfunction in each of those cells, tissues dysfunction, organs dysfunctions, patients do very poorly. Now, when we measure out, the endpoint of all of this is actually pyruvate. But we can't measure pyruvate at the bedside. It's a very unstable assay. We just can't measure it. So the byproduct of pyruvate is actually lactate. And that's why we measure lactate. Lactate is an indicator to tell us if a patient is aerobic or anaerobic based on perfusion of their mitochondria. If they're being perfused, lactate's low. If they're not being perfused, lactate starts going up. Now, mind you, there are other things that can cause elevations in lactate. This isn't 100% for that, but it gives you a good trending point as to where your patient is and what we should be doing. And the reason why that's so important to know if your patient's aerobic or anaerobic is because if you're anaerobic, no matter what you throw at that patient, it's not going to work. Catecholamines aren't going to work. We had a 19-year-old patient that came in 3 years ago, and came into the CCU service that was on wide open vasopressors, wide open inotropes, and he was dying in front of their eyes. And when I walked by and I looked at their blood gas, I just threw an eye. The guy had a pH of 6.8. So none of this stuff was working. No matter what they did, none of it was working because he was so anaerobic. And I kind of whispered in the resident's ear, give him some bicarb. Get his pH above 7.2. And they did. And next thing you know is they were weaning vasopressors and inotropes like crazy because they were able to shift him from being so acidotic to actually perfusing. So it's important to know what your patient's pH is. Now, are there any studies out there that back up what I'm saying? It's like, absolutely. Jansen and their group took a look at lactate in the ICU, and they measured it. If the lactate was elevated, then they looked at SCVO2 and brought it down the algorithm from there. And they did it a lot like early goal-directed therapy. They had patients that were in the control group versus the lactate group, and they watched them for up to 72 hours. And what they actually found was that patients that were being treated based on their lactate and their lactate clearance got more fluid than the control group did, less fluid late than the control group did. They did get more red blood cells, and that's always been one of those controversial points, whether or not you should give blood and how much you should give. They got more inotropes, more vasodilators, and more vasopressors than the other group did. And when you look at it, although you may not meet statistical significance here, there's a 10% difference in mortality. And that 10% holds out all the way to, they went and looked at it for over 200 days. If you can decrease somebody's mortality by 10% just by following a blood test and make sure that it's clearing, and knowing the pathophys and the rationale behind it, to me it makes perfect sense that you would do that. Now, Puskirch and their group took a look at lactate clearance, and in their study, they took a look and measured patients' lactate, standard of care in their particular institution to treat the patients, and followed their lactate out for 6 hours. And what they found was very simple. If they normalized their lactate, their survival was 93%. If they didn't, it was 67%. All the way down to 50%, 10%. And look at the difference. By following one particular blood test, you're able to see whether your patient's aerobic or anaerobic and whether the interaction and the intervention that you're doing is working to make sure that you're perfusing your patient, and it makes a difference in your patient's outcome. Now, some people are MAP people. Some people are not MAP people. Do you believe that everybody's MAP should be 65 millimeters or greater? Personal choice. Don't care if you believe it. Don't care if you don't believe it. Whatever it is that you believe, kind of like crystalloid colloid. Whatever it is that you believe, you go from there. But in this particular study by Huink and their group, they actually combined it. And what they found was that by improving perfusion, normalizing your lactate, improving your MAP, patients had the best outcome versus patients that you didn't do that to. So by following your lactates, whether or not you want to push your MAPs or not, patients do better from there. So we're lactate people up at MI, and we believe in using our lactates. Another thing that comes to mind when we talk about the sepsis patient is how much volume should they get? Let's face it, when I was an intern and I asked my resident, how much fluid should I give this patient? My resident told me, give them fluid until they gurgle. I didn't know how to measure gurgling, but I figured that probably wasn't the right answer. But that's what I was told. So it doesn't matter how much fluid we give a patient. The answer is yes. If you volume overload your patient, your survival goes down. And study after study shows that patients who have lower volumes for I's and O's as time goes by have a better chance of surviving than patients that don't. So the question then will come in, how much fluid should we give our patients? And it all comes back to looking at our Starling curve. Where is our patient on their Starling curve? Are they fluid responsive or are they not fluid responsive? If you give them fluid and their stroke volume improves, they're on the uprise of their Starling curve and they're preload responsive. Once you get to them plateauing off here, you can give all the fluid in the world, you're not going to improve their cardiac performance. And as a matter of fact, one thing that you never see in diagrams related to the Starling curve is that if you keep pushing fluid, it actually does this. It's what the Starling curve actually does. So you need to know where your patient is on their Starling curve as to when you're giving them fluid, how much fluid you should be giving them, because if they've already plateaued off, they're down here. Your heart failure patients, your renal patients, they're down here. Giving them fluid, you're going to kill them. And these patients would do better with some sort of vasoactive medication to improve their cardiac performance. So you need to know where they are. Another thing you need to know is you need to know where are they in their phases of fluid, of hemodynamic resuscitation. Are you in the rescue phase where they're in shock, and if you don't do something within the first couple of minutes, they're going to die. Or then the optimization phase, where you're taking what you just did, optimizing it, because you now have time. You've got several hours where you have time to optimize them. Are you in the stabilization phase, where over the next day or two, you start maintenance fluids, you start decreasing some of your vasoactive medications? Or you're in the de-escalation phase, where you actually start diuresing people and getting them off everything that you've done because you've gotten them through what put them in the ICU in the first place. So you've got to know where you are in your treatment phase in those particular patients. Otherwise, they're going to end up here. So one of the first studies that came out was the early goal-directed therapy study by Manny Rivers, Bryant Wynn, and their group, trying to help tell us how to volume optimize our patients. And everybody's pretty familiar with the study. It came out in 2001. It basically was in a single center institution where they took patients that met criteria for severe sepsis, septic shock. They were put on a management algorithm, and the enrollment began about 1.4 hours from the time that they popped in to their ICU and their ERs, I should say. Patients were divided into early goal-directed therapy versus standard therapy. The physicians in the ICU were blinded. The ER guys knew what was going on. They stayed in the ER for the first 6 hours. Then hours 7 to 72, they moved to the ICU. The ICU docs were blinded. They didn't know which arm the patients were in, whether they were in the early goal-directed therapy or the standard therapy arm where they were monitored by those particular parameters. Now what they found was that the guys in the ER were volume resuscitating based on whichever side of the algorithm they were on. Then, like I said, they got shifted from the ED to the ICU. And at the end of 72 hours, there was about 105 cc's of fluid difference between the two groups. But the outcome was significant. Look at the difference in survival. All patients in hospitals, a 16% improvement with EGDT. 28-day was 16%, 60-day was still 12.5%. So based on that, people were like, wow, this is great. Everybody needs to do EGDT. And what is this SCVO2 of which you speak? What is this great new thing that we are monitoring? Well, central venous oxygen saturation, basically you measure occult tissue hypoxia and you measure the inadequacy of arterial pressure, to be honest with you. When you look at patients and you look at vital signs, up to 50% of patients will be hypoperfused despite normal vital signs and a normal CVP. If you look at blood pressure, most patients will maintain a decent blood pressure even though they don't have adequate flow, and then they eventually will fall off the cliff. So this gives us an early indicator of whether our patient has hypoperfusion or not. And it's very, very similar to SVO2, which we measured for years with our PA catheters. We're looking at a balance between oxygen delivery and oxygen consumption, and it measures the same four factors: cardiac output, hemoglobin, oxygen saturation, and oxygen consumption. Normal SVO2, again, like I said, it comes from the PA catheter. It measures an admixture of blood from the IVC, the SVC, and the coronary sinus. Normal 60 to 80, we say look for 70. And SCVO2 measures it in the superior vena cava. It's an admixture of blood from the upper part of the body. And we measure it again, 60 to 80, we say 70%. SCVO2 will typically be higher than SVO2 because SVO2 has IVC blood mixed with it, and the critically ill patient's blood shunts away from the non-vital organs usually being the GI tract, skin, muscles, etc. GI tract, which drains into the IVC, is less oxygenated, and therefore your SVO2 will be lower than your SCVO2. And like I said, the indications for it, we look for oxygen imbalance. We assess and adjust our therapy when we don't want to put a PA catheter in. It's a surrogate for this, and it was vindicated and used by EGDT in the sepsis bundles from there. Now, for years, people believed in early goal-directed therapy. People quoted it. People lived by it. They loved it, except for emergency room physicians, which hated it. Obviously, they hated it. And the reason is because they had to put a catheter in, because you had to measure what the SCVO2 was and then initiate treatment from there. And the guys in academic centers that had residencies, they were fine with it because it gave the residents a chance to put a line in, and they were good with it. But when you took a look at the private practice guys that are working based on RVUs, they don't want to take time to put in a central line and do all this. They just wanted to get the patient upstairs. So there's a little bit of pushback from there, but all in all, people believed in early goal-directed therapy. It changed the way they practiced, and then all of a sudden, the guys at UPMC in the mid-2010s said, wait a minute, this is a single-center study. We don't buy it. We're going to do our own study. And that's where the process trial came. The problem with the process trial, it wasn't very well regulated in that people were able to kind of do what they were going to do on their own. And they had three groups. They had the protocol-based EGDT, just like in the original study. They had the protocol-based standard therapy, just like the original study. And then they had this third arm called usual care. And usual care just meant that the docs could just treat the patients however they wanted to. And at the end of the day, what they found was that clinically there was no statistical difference in outcome between the three arms. There was no difference. So based on that, the guys from UPMC said, see, based on our study, early goal-directed therapy is bogus. It doesn't really work. Now, the NSIX trial and the ARISE trial came out of New Zealand and Australia, did the same thing. And again, they actually just used two arms. They took out the early goal-directed standard therapy arm. They just used EGDT and usual care. Same thing there, no difference. And then our friends over in England did the PROMISE trial. They had the two arms, and they too found no difference. So based on that, people started screaming that early goal-directed therapy doesn't work, et cetera, et cetera. And those of us that did a little research into it thought to themselves, well, that's not true. Think about it. This study, EGDT, came out in 2001. Prior to 2001, there wasn't standardized how to volume resuscitate a patient. All of a sudden, this study comes out, people realize you've got to get fluid early. You've got to do all this early in a patient's care, and then you back off the volume. And they may need vasoactive medications to improve. And people did that. And that became usual care. And so although there's no difference between EGDT and usual care in 2018, there shouldn't be. Because if you read the literature and you train properly, your usual care is EGDT. You may not be following SCVO2, but you're doing the same thing. You're following something. You're following IVC checks. You're following passive leg raises. You're following something to see what your volume optimization is. So that's, in my mind, yeah, you're right. There's no difference in mortality because there shouldn't be, because you're doing the same thing these days. And actually, this article just came out by Bryant Wynn and their group, took all those studies, put them together, compared them, and what they found was that you're right. There is no difference because, again, all of a sudden, this is now usual care. So, how do we know? If we're not measuring SCVO2, how do we know where we are with volume optimization? Here's some of the other stuff that I wanted to throw in. Bedside echocardiography, bedside ultrasound. We take a look, we look at patients' IVCs. We can predict fluid responsiveness. We can predict where a patient is on their Starling curve just by putting an ultrasound probe on the patient's belly and looking at compressibility of their IVC. And if you look at it, it actually is a lot more predictive than CVP. When you look at your ROC curves, it's up to 80, 90% predictive of where a patient's going to be on their Starling curve. And as a matter of fact, they found that if it's compressed by more than 18%, that patient is on the upward swing of their Starling curve, and they're actually preload responsive to a fluid challenge. Less than that, then they're not going to be preload responsive. Patients that are spontaneously breathing, that's always a big deal. Everybody throws that in. Sure, the paralyzed patient on assist control, yes, these numbers are accurate, but you take the spontaneously breathing patient, none of this stuff makes any sense. Truth of the matter is that's not true. 2017, Coral and their group took a look at patients and said, okay, fine. We will look at IVC with spontaneously breathing patients. And you know what? 84% predictability just by putting a probe on somebody's belly and seeing if their IVC is compressible or not will tell you whether or not they're preload responsive. Non-invasive, easily reproducible to the point that you do it, You see if they're compressible. If they are, you give them a volume challenge, you can repeat it. It's right there. The learning curve is like this. It's super easy to do. And there are very few patients that you cannot get a window on. Well, you know what? If you can't get a window on, there's another way around it. But take a look at your patient. This is what POCUS is, point of care ultrasound, which is a horrible, horrible name for it, but yeah, the critical care docs decided to call it POCUS. So they did. So basically, in your patient, they're hypoperfused. Are you considering IV fluids? The answer is no. You're off the algorithm. If the answer is yes, go ahead and do your IVC. Are they compressible? Yes or no? If they're compressible by more than 25% in this study, it says go ahead, give them a fluid challenge. If the answer is no, then they need a vasopressor from there. Very simple, very easy in your spontaneously breathing patients. In your patients that you cannot get a good window of the IVC, guess what you're going to do? You're going to go to the IJ. How many times did you try to put an IJ in and you just can't get it in? Why? Because it's compressible. Those patients are dry. Look at their IJs. It'll tell you where they are on their Starling curve. Again, non-invasive, very predictive of a patient where they are on their Starling curve. What about arterial pressure-based waveform systems? When we talk about it in this institution, we use the flow track. But there's PICO, there's LIDCO, there's lots of other things that are out there that are going to tell us indicators of preload responsiveness just based on stroke volume variation, systolic pressure variation, pulse pressure variation, or the big one, stroke volume optimization. At the same time, it's also going to give you measurements of left ventricular function by looking at cardiac index and stroke volume index. And which one do we use? Truth of the matter is, there's a bunch of them out there. And I don't have any sort of financial investments in any of them. So use the one that you're most comfortable with. But get comfortable with one and then learn how to use it properly. And it's very, very predictive to teach you where your patient is on their Starling curve and who's going to respond to a fluid challenge and who's not. It's just knowing your number and knowing where you are on your curve from there. Is it predictive? The answer is absolutely. 80 to 90% predictability, just knowing what those numbers are, telling you where you are on your curve. Passive leg raise. We talk about it all the time. Well, maybe not all the time. We talk about passive leg raises. This particular article I include for you by Cherpanoff, just to say that there's many studies that are out there. If you want a meta-analysis on it, this is a good one to look at. And again, this study will tell you, are they on their curve? When you do a passive leg raise, if you see a change in their stroke volume, you lift the legs up, their stroke volume improves, you know they're preload responsive, put the legs down, give them a fluid challenge. If there's no change in their stroke volume, then you know that they need a vasoactive medication from there. This particular study by Monet in their group, because Monet is pretty much the king when it comes to passive leg raises. Patients on a stretcher, you lay their head down, you bring their feet up. You follow their cardiac index, cardiac output, stroke volume, whatever you want to follow on the device that you're using. If it improves by doing that and shifting them, you're giving about a 500 cc fluid just by lifting the legs, put them back to the normal position, give them fluid, give them that much, and then reassess it from there. And just a good little picture from that particular standpoint. Now, that sounds great. We did all that. We're comfortable where we are. 2015, all of a sudden, you've been hearing about it for years. CMS comes in. Here's your core measure. And it's been driving us insane ever since. In 2016, here they said it's been 4 years, we're changing our definitions. And we're changing our definitions for sepsis and septic shock. Why? Because basically, SIRS is overly sensitive, lacks specificity, and sepsis and severe sepsis is confusing. So basically, there's a couple articles relating to the fact that SIRS is an inflammation. It's not based on infection or sepsis, and too many people meet criteria for that, and it just doesn't point us in the right direction. So based on that, here are the new definitions that came out in JAMA, February 2016. They dropped SIRS. Sepsis is more than infection with SIRS. Sepsis involves organ dysfunction, and therefore, since sepsis involves organ dysfunction and it's severe, there's no need for severe sepsis, which made me cry, because I love severe sepsis. Definition of sepsis is, from here on out, a life-threatening organ dysfunction caused by dysregulated host response to infection, and you're going to see an increase of the SOFA score of at least 2 points. From there, they said, okay, we got the sepsis part. Here's septic shock. Septic shock is a subset of sepsis, profound circulatory, cellular, and metabolic abnormalities associated with a greater risk of mortality than sepsis alone. They have fluid optimization, are on vasopressors, and their lactate is greater than 2, is your new definition for septic shock. Third article, same JAMA. They came up with different scoring systems. They looked at SIRS, said, nope, we're not using SIRS. They looked at the SOFA score, they looked at the LOD score, and then they invented this thing called a Q-SOFA score, which we'll talk about in just a second. And here's the SOFA score, anywhere from 0 to 24. The higher the score, the sicker your patient. Your criteria, your categories, I should say, are respiratory, coagulation, hepatic, cardiovascular, central nervous system, and renal. Everything gets points. 0 to 24, like I said, the higher the score, the sicker your patient is. Now, the problem is that the SOFA score is very complicated. You got to pull out a little thing on your phone, try to calculate it, and that's fine if they're in the ICU and they're sick and you're trying to figure out how sick they really are. But the guy coming in the ER, the guy on the floor that you're getting called for, you just need to be able to do something quick at a screening test, and that's called the Q-SOFA. Are they hypotensive? Do they have altered mental status? Are they tachypnic? Greater than 2 indicates a patient who is at risk of having sepsis and having a poor outcome. It needs to be looked at closer. If none of these criteria are met, the patient's most likely not septic, and they can be watched where they are. When they looked at predictability, the Q-SOFA score did not do well in the ICU because everything can cause that in ICU. But on the floor, it works out very, very well. 81% predictability. In the ICU, there's a lot of other factors that come into place. So then they said, what happens if we add lactate? Because Grier likes lactate. Well, unfortunately, it didn't change your Q-SOFA. Q-SOFA stayed the same with those 3 predictable factors from there. So based on that, they said, here's our algorithm, follow it down. Your Q-SOFA score, your new definition of sepsis, and your new definition of septic shock from there. Now, sorry guys, I just thought it was kind of cool. I thought it was a funny sign, so we're going to have it. So they said, well, what about SIRS versus Q-SOFA? Which one's better? You know, we've used SIRS forever. Why can't we still use it? Truth of the matter is, Q-SOFA is actually more predictive than SIRS in patients who have sepsis from that standpoint. So where are we now with all of this? Tired. So we've got our sepsis 3 right here, where we've changed all of this to now basically our organ dysfunction related to our SOFA score of those 6 particular categories on our new definitions. We've changed a little bit of what we're doing, you know, how we define things, how much fluid we're giving, how are we monitoring patients. We're not using CVP and SCVO2 anymore. We're looking at some of these dynamic measurements, stroke volume variation, stroke volume optimization. We're looking at lactate. We're still targeting a MAP of 65, no matter what we do. We're still going to have that in there. But now norepi, epinephrine. We're not using dopamine. Steroids, again, you're either pro steroids or con steroids when it comes to how you're doing it. If you're doing steroids, it's 200 over 24 hours as opposed to the Q6 hour, Q8 hours. It's a continuous infusion now. Antibiotics, we're still for antibiotics. Source control, we're still for source control. We're still doing low tidal volumes and going from there. Some of the new stuff that's come out. How many people have heard about Merrick's study or looking at vitamin C? Well, this came out last year, and everybody went crazy. All we have to do is give people an orange, and they're going to survive sepsis. Not really. But what they looked at was septic shock patients, and they looked at 7 months before and after the study. The treatment group was randomized to get hydrocortisone 50 Q6, vitamin C 150 Q6, and then thiamine 200 Q12 versus the placebo group, which got none of this stuff. And what they found was a significant decrease in mortality, a significant improvement in procalcitonin, a decrease in vasopressors and a decrease in your SOFA score. That's great. Everybody just jumps on the bandwagon. Truth of the matter is, where we are right now with vitamin C, there are 3 major studies going on right now at different centers looking at the reproducibility of this particular study of whether or not utilizing vitamin C is really going to make a difference in outcome. And I hope it does. It's inexpensive, it's easy to use, it's safe, and hopefully it will be something that we can add to our armamentarium. In addition to new things that have come out in the last year, angiotensin II for vasodilatory shock came out in August of 2017. The article, Athos 3 that came out. Here's just a little study just showing you how you get to angiotensin II. And basically what it looked at was patients that were found to be in septic shock on vasopressors were randomized after 6 hours to angiotensin II or placebo. What they were looking for at 3 hours was their primary endpoint. Were you able to wean your baseline vasopressors, or did you have to go up by starting angiotensin II? Your secondary endpoints were, was there a change in your SOFA score? The big one was cardiovascular SOFA score. And then there were some other things looking at norepi equivalence, mortality, etc., although Athos 3 was not powered for mortality. And what they found was that within 5 minutes of starting the drug, you actually can see a hyper response of the patient's MAP going up to over 75. And then as you taper the dose and stabilize it, the blood pressure stays up. And as you can see here, there was a significant drop in baseline vasopressors just by adding angiotensin II to that. The study was then looking at patients using angiotensin II, the septic shock patient, who were on CRT. And what they found was, again, patients that were started on angiotensin II had a better outcome, were able to wean off vasopressors, were able to wean off renal replacement therapy much better than the patients that did not get angiotensin II. So again, something new in our armamentarium in septic shock patients. Where will it land? We're waiting to see. There's plenty of studies out there that are showing us positive or negative from that particular standpoint. Other things. We talk about procalcitonin all the time. I mean, you probably, those that are around with us are probably sick and tired of hearing me talk about lactate and procal. Procal is a marker, a biomarker that we use to measure bacterial infection, present or absent in our particular patients. And one of the reasons we look at it is because of the timeline. Now, I mean, I grew up in the era of the silver bullet, where we would do clinical research study over clinical research study. We did so much clinical research when I was a fellow in my early years as a faculty member, looking at that particular biomarker that's going to pop, and we're going to have the anti-biomarker for that, and we're going to cure sepsis. Unfortunately, we didn't find it. We did anti-TNF studies. We did anti-interleukin studies. We did all this stuff, and none of it came back positive for showing a difference in patients' outcome. And the rationale behind that was simple. They pop up way too early. By the time a patient's presenting to you in the emergency department or in the ICU, it's already peaked and fallen. We couldn't catch it. I mean, people aren't going to just show up every couple of days going, hey, can you check my TNF levels, see if I'm getting septic? You just couldn't catch it. But one of the things that we found about procalcitonin is that it starts going up about hour 2 and will peak at hour 24 and then start falling off. So you have time in that patient when they're presenting to catch them and see what direction they're going. Are they truly septic? Do they have a truly bacterial infection? And how bad is it and where's it going from there? And when we compared it to other biomarkers such as lactate, interleukin, and CRP, look at it. It's awesome for sensitivity and specificity. So that's one of the reasons we do that. And when you look at where is it produced, you're going to see in the normal healthy person, you're going to see a small amount being released in the thyroid and a little bit in the lung. In the truly bacterial infected patient, every organ but the heart will produce procalcitonin. So we're going to catch it if a patient has an infection. And it's because it's a hormokine. It's a regulatory substance produced in an organism and transported into tissue fluids to stimulate specific cells into action. So basically here with your bacterial infection, it comes in and it will stimulate as a hormokine. Viral infections has interferon, which will not stimulate this particular hormokine to release it from the Golgi apparatus into the bloodstream. And that's why we say when we talk about procals, we're talking about if it's elevated, it's a bacterial infection, whereas if it's not, it can be an infection of another source, but it's not bacterial that's causing the problems. This particular graphic shows you the levels that when we measure it, you know, what's negative, what's positive, when should we start antibiotics, etc. And I know that in our world, you know, when we see a procal of 0.3, 0.4, we're like, oh, it's negative. But in actuality, it really is a positive procalcitonin. We're just so used to seeing procals of 30, 40, 360 that a 0.5 or 0.6 just doesn't get our attention. So we just kind of trend it from there. But the first really big study that came out in 2010. It came out in Lancet, and it was the PRORATA trial. And what the PRORATA trial was looking at was two things. In septic patients, or patients that were critically ill, we're going to follow procals and our control group. And we're going to see if there's a difference in mortality or a difference in days without antibiotics. And what we found was that they would measure the patient's procal. If it was less than 0.25, they discouraged antibiotics. Between 0.25 and less than 0.5, it was still discouraged. But if you're really thinking that the patient's got some sort of bacterial infection, just redraw your procal in 6 to 12 hours. As your level got higher, they encouraged antibiotics, and they strongly encouraged it if it was greater than 1. And what they did was they followed the patient's procals every day. And when they dropped is when they would recommend stopping the antibiotics from there. And they found that across the board, procalcitonin does not save lives, but it significantly decreases the number of antibiotic days. Now, building on that, the Moses trial came out, and what the Moses trial showed us that I think is even more important is that if you do not decrease your procalcitonin by 80% in the first 96 hours, your mortality rate skyrockets. And that's because you've got the wrong antibiotics. You're treating your patient in the wrong way. So you're going to follow your procals, you're going to follow them for 96 hours to make sure that they drop by 80% or not. And simple, easy way to do it, just follow daily procalcitonins on your patients from there. Another thing that we do a lot of is therapeutic plasma exchange, TPE, in our sepsis patients. The biggest study to date only has 23 patients, guys. We've got to get our data. We have over 350 patients that we've done TPE on. And it's shown that we are able to drop our norepi requirements with TPE. And a big thing we do is we do it for thrombocytopenia, because I told you guys that thrombocytopenia is an indicator of survival and death in patients with septic shock. Your platelet counts come up significantly with TPE. So we've got the data, we're crunching it, and stay tuned. Maybe in 2019 when I do the sepsis update, Dick, we'll be able to put our own study up there. This is a nice summation slide right here, kind of showing us from step A to step B what we should be doing to treat our patients, all of which we've talked about, definitions, volume optimizations, which vasopressors to use, if you're going to use steroids, what kind of steroids, antibiotics, etc., from that particular standpoint. And yeah, I did 131 slides in less than an hour. So hopefully I didn't go too fast. Hopefully you got something out of it. I appreciate y'all coming. I'll be glad to answer any questions. Otherwise, I need more ice in my tea. So other than that, thanks, guys.
Laurie,
Oh, yeah.
I think there's the debate about which antimicrobial agents to use. It depends on your institution. So in order to, if you know your data with regard to gram-negative, gram-positive in sepsis, you need that information. Uses the antibiogram to guide you. In this institution, we're fortunate that we can still use pretty well any gram-negative agent that's on the chart at the present time. I think the procalcitonin, point of procalcitonin is very well taken. One of the difficult things that goes outside of, yeah, that.
You're Your attention, please.
So is that in October, in October of 2015, CMS came out with their guidelines, which all of you should really understand. It follows into a core measure. Now, the core measure also says you should give everybody 30 mils per kilo when they enter into the severe sepsis.
Notice I didn't mention that because I don't agree with that.
Right. It's a challenge, all right. But I mean, how you monitor it, most important, and that you monitor it is important.
Right.
I mean, that's the issue. Going back to the patient and re-examining the patient. But again,
And documenting it.
and documenting it. Well, the trick with the definition was in October 2015, the CMS had their definition, and in February, the definitions of 2016, the definitions changed. So in order to get paid, you have to use the old definition, not the new definition. And if I might say, when we're talking about sepsis, don't forget, it really has to do with an infection or suspected infection, not just a febrile state. And we're doing it all over charts. I see this is sepsis, and you know, this is urosepsis. Those definitions actually don't get you paid for what the work you do. You have to, so look at the coding system as well. I know you're looking at, we look after the patient, survival is our goal, and to that end, sepsis, when the patient has a diagnosis of sepsis, it's not over. The chance of that patient dying in the next 12 months is still quite high. And the after effects of sepsis, which is in the literature too, but you need to look at that and not say, well, we got them through this, we did all our work, we're all happy. There's got to be the follow-up after they leave the hospital. Thank you. That was fabulous.
Thank you, Ed. Appreciate it. Thanks, guys. That was great. Oh, I'm sorry.
Predictably, you've given us a great review and made the point that details matter. You got down to refer to as micronutrients. It makes perfect sense since I'm a co-founder and likewise magnesium. I didn't hear magnesium specifically mentioned. Knowing how thorough you are, I'm sure you like that. Magnesium is a cofactor for life.
432 every day. 432. Getting across and back.
And likewise, magnesium is a good cofactor for any ATPases. You have all the ATP. You have bucket full of ATP. Magnesium as a cofactor and ATP not really what possible. That was like I said, predictably, Laurie, Grier.
Thank you, sir.
Thank you very much.
Thanks.